Hello, I'm Norman Swan. Welcome to this programme on viral hepatitis. In Australia, the number of people diagnosed each year with hepatitis is increasing. There are probably about 300,000 people living with chronic hepatitis B or C, and in Australians it's 1 in 12 people. Viral hepatitis is a major public health issue. Many thousands of Australians remain undiagnosed, yet early detection remains the best option for treatment and secondary prevention. Tonight we're going to look at recent developments in hepatitis prevention, diagnosis and treatment, with a particular focus on people living in remote and rural areas. You'll find a number of useful resources available at the Rural Health Education Foundation's website, rhef.com.au. Let me introduce our panel. Professor Bob Beattie is currently the Clinical Director of the Viral Hepatitis Programme with the Australasian Society for HIV Medicine, ASHM. He's also Chair of the Academic Board of the Sydney Institute of Health Sciences and Chair of the Alcohol and Drug Research Committee for New South Wales Health. Welcome, Bob.
Thank you.
Bob has worked in Sydney and in Newcastle in major teaching hospitals, as well as regional New South Wales and Indigenous communities in the Northern Territory. Dr Ben Cowie is an infectious disease physician and an epidemiologist with the Victorian Infectious Disease Service at the Royal Melbourne Hospital. Welcome, Ben.
Thank you.
Ben's a senior lecturer in the Department of Medicine at the University of Melbourne as well. He has a particular interest, clinical and research interest in viral hepatitis, focusing on the epidemiological research to guide the development of public health responses, particularly to hepatitis B. Tracy Jones is a hepatology nurse practitioner. Welcome, Tracy.
Thanks, Norman.
Are you one of a kind?
One of 5.
One of 5. In fact,
very special elite group.
In fact, Tracy's worked in the field of hepatology for 16 years and with a focus on hepatitis C, and in fact she was the first authorised hepatology nurse practitioner in New South Wales. And she's a founding member and past president of the Australasian Hepatology Association and member of numerous committees. When do you do your day work?
Yeah.
So what are you allowed to do as a nurse practitioner that you weren't as a common or garden nurse?
I'm allowed to prescribe from a set formulary, and I can also manage patients as a sole practitioner in a collaborative arrangement with GPs and or specialists, but I'm able to make dose reductions in terms of the S100 therapies that they're on without consulting with the medical specialist if I feel that it's entirely appropriate,
so
because I have to be able to justify what I do.
You're allowed to dole out pegylated interferon like Smarties, are you?
No, I'm not allowed to write the scripts for it because the S100 guidelines do not allow nurse practitioners to be able to write scripts, which is an issue we'll discuss later.
Yeah, Tracy, you'll sort that.
But I can do the dose adjustments as appropriate.
Good. Inam Audi holds a degree in nursing and a postgraduate diploma in community health. Welcome, Inam.
Thank you.
For the last 27 years, Inam has worked in a range of government and non-government settings, both in Australia and Israel. Currently, she manages Peace Multicultural Services for Relationships Australia in South Australia. Peace provides services for people from culturally and linguistically diverse backgrounds who have viral hepatitis and or HIV/AIDS. So welcome to you all.
Thank you. Thank you.
It's an alphabet soup, Bob, of hepatitis. Now, you know, in my notes, there's no G. You know, when I was training, there was a G.
There was. There was an F as well for a short period.
Yeah, well, let's
of time.
not get rude about these things.
No, there was. G was there in the patients who had abnormal liver function tests, but it was ultimately decided that this virus was not causing hepatitis. It actually has some benefits to people with liver disease. People who have transplants who get Hep G, or whatever it's now called, actually do better.
Oh,
so
really?
we're left with A to E to discuss this evening.
Okay, Ben, what's the trend here?
The trend in hepatitis A diagnoses?
Well, no, we'll come back to hepatitis A in a moment, but just the A to E, what's going on? Because I said in the intro they're increasing.
Yeah.
What's increasing? Incidence? Prevalence?
Well, particularly prevalence of hepatitis B and hepatitis C, which are the viral hepatitis which develop chronic infection. We know that the numbers of people living with chronic Hep B and Hep C are increasing every year, and in fact it's probably approaching 400,000 people now living in Australia with B and C, and that's increasing by several thousand per year for each of those. For hepatitis A, for instance, the number of new diagnoses or incident infections has actually been falling. It'll be interesting to see what the respondents have actually felt in terms of the number of cases per year.
We've actually got an early question here from Marissa Pilla in Northern Queensland. Do the hepatitis A and B immunisations decrease in effectiveness over time, and do we have to give boosters?
Okay, so that's an excellent question. For hepatitis A
Marissa
vaccine,
always asks excellent questions.
So let's start by saying for people who have normal immune function, so they're not immunosuppressed patients, If you vaccinate someone against hepatitis A and they develop a response, if you've given them 2 doses spaced by at least 6 months, then that creates prolonged immunity, and there's no need for boosting down the track if they do actually mount an immune response. And it's a very effective vaccine in the proportion of people who do develop an immune response.
So you've got a 17-year-old doing the year, their gap year, and they get Hep A immunisation.
If they have 2 shots spaced by at least 6 months, then you can anticipate that a very large proportion, sort of 95% plus of those 17-year-olds will develop immunity, and that will be for the long term, and they do not require further boosting down the track. For hepatitis B, again, for someone who has a complete course of vaccination, who doesn't have any other chronic medical problems and who has a normal immune function, if they mount an immune response to the hepatitis B vaccine, there is no indication for boosting down the track, and they're immune for life.
They are. Okay. So we're coming back to the growth in this. So this is a combination of prevalence. Why would hepatitis B be going up if we've got immunisation?
Yeah, and that's, again, it's a really good question. So the infant vaccination program here in Australia, which has been universal since 2000 and has had coverage rates of approximately 93 to 95% of newborns in Australia, is really important. And it's not only cost effective, it's cost saving. So it's a preventive health best buy. However, it's not going to have any impact whatsoever on the proportion of people living with chronic Hep B in Australia, because probably more than 90% of new chronic infections entering the population enter through migration and not through domestic incident infections that progress to chronicity.
And is that an issue for the migrant populations? Did you deal with them all the time now?
Yes, we deal a lot with hepatitis B, by far a lot more than hepatitis A, and more than hepatitis C. I think the issue for migrant communities is quite big, quite challenging for the healthcare system. I mean, let's acknowledge that our healthcare system is quite complex, and it is built for a culture that relies on self-responsibility and self-management, as opposed to people from other cultures who rely heavily on collective responsibility. Collective responsibility is made of doctors, nurses, family members, and sometimes even community leaders.
Mm-hmm.
So that poses a lot of challenges for people from other cultures, and also add to it the linguistic and the linguistic issues and the way people describe their feelings, their experiences. People have different experiences and different way of interpreting diagnosis or relating or understanding diagnosis.
And they've presumably got a generic term like jaundice in whatever language it is,
Totally.
rather than
I mean, there is a fundamental...
hepatitis B, thank you very much.
Yeah, there is a fundamental difference.
Are they frightened of it in terms of the impact it might have on citizenship or something like that?
No, but there is a belief that, especially for new arrivals, they believe that screening for hepatitis can be perceived as a test. If I get positive results, then I might be deported. And if it's
so you think they shrink from testing?
I think they're quite reluctant to do testing unless we engage with them more effectively. We need to engage with them in a way that they understand it. It relates to their context, their way of understanding the word, depending on where they come from, the reasons they arrive, the pre-migration history. So people who live in refugee camp would have a completely different experiences than someone who comes as a business or international students, So there is no one way of engaging with people of other cultures.
Which are notifiable?
So all of these conditions are notifiable. There's different legislation or regulations in states and territories regarding which are notifiable just by the lab or also by the treating clinician. And many of them the regulations specify that they need to be notified by both.
And how do you do it?
So there are contact numbers and website-based notifications, and also fax numbers in all the states and territories for those where clinicians are required to do it. For testing laboratories, they're required to do it, and usually they do it electronically to the health department.
Tracy, what do you think are the main clinical challenges with the viral hepatitis?
I think the clinical challenges is one, educating the workforce across the country, and two, is engaging that workforce with the patient population.
What do you think are the biggest myths that people come to you, the consumers and patients come to you with? Or even other clinicians?
Well, some people don't know that there's any treatment available for the different viral hepatitis diseases, and also the acronyms that we use. The medical workforce, we're very, very good at shortening things because it makes it easy for us to manage it, but acronyms like HIV, HBV, HCV, They all sound the same, particularly to people, from the migrant communities that don't have a good grasp on the language or a good understanding of what we're telling them.
What about challenges in remote and rural Australia, Bob? You spend
I think there it's workforce numbers, having enough people in the situation to be able to do the assessment and treatment. I think it's also communities out there do have different understandings of disease than those living in cities, for example. Our Indigenous colleagues do not think about health the same way we do. And I think we've just tried to impose a Western model on those and wonder why it doesn't work as well.
And to what extent are we still forced into major centres to start treatment?
At the moment, that's been an issue. You had to go to a place where you could get a liver biopsy for hepatitis B and C for a number of years. C was removed in 2006. But that's the drugs themselves had to be dispensed from a major hospital setting. And so a lot of people in some parts of the country just didn't bother because they had to travel to get to a treatment centre.
But there's more shared care now, isn't there, Ben?
Yeah, that's absolutely true. So community-based care, including shared care, has been the norm for HIV for a long time. Most people living with HIV are treated in the community now. For hepatitis C, shared care programs have been around for a substantial period of time, and many hepatitis services in hospitals have been engaging more with shared care and also, again, GP-led care. For hepatitis B, the first pilot programs for GPs to be able to be trained to prescribe hepatitis B drugs, hopefully starting next year in 6 jurisdictions in the country.
We move quickly, don't we?
We really, well, yeah, that's the question of perspective, I guess.
Can I just make a comment, though, about the term shared care? I mean...
Or is it dumped care, is it? Was that what you're trying to say?
No, but I just think, we use this title like it's a brand new thing and it's just been invented and it's what we're doing. But the reality is that the GPs and the nurses across the country are looking after these patients, and they're referring their patients to us and inviting us really to be part of the overall care and management of people.
So you're the ones doing the sharing?
Well, I just think that we all need to work together. It's part of, I guess, a triangle. We're just part of a continuum of care. It's, GPs, us and the patient. We all have to work together.
Can I add to, you asked Norman about the challenges for clinical challenges, and we're talking about shared care. And there is fundamental, issue here when we're dealing with people from other cultures. We have to really look at the adherence to treatment and adherence to monitoring or adherence to a care plan. It's not enough to just have a care plan that's negotiated between a nurse and a doctor. We have to look at how is that relevant to people from other cultures? What would prevent them from coming to or adhere to that particular plan? And I don't think we are doing quite well in this area. And I can't comment on what's going on in the country area, but certainly that's not happening.
So their community unit, if you like, is whether it's family or extended family or extended group.
Yeah, especially if people new arrivals and they're not familiar, not familiar with the healthcare system, but not familiar with using the public transport, or sometimes they have a number of kids that they have to look after, and that prevents them. I'm familiar with a case where an appointment was made to go to the hospital early in the morning when the mother was really busy getting the kids really ready to go to school, and like as simple as those things.
What's the extent of underdiagnosis of all the hepatitis?
You went the second time.
Yeah, that's right.
Look, that's a really important issue, and it's perhaps most important for those viral hepatitis B and C that have chronic manifestations, and that appropriate diagnosis early can lead to intervention to either, in the case of hepatitis C, cure the infection. And in the case
You're actually going as far these days as saying cure.
Yeah, sustained virological response. So yes,
right.
A cure. And for hepatitis B,
which answers one of the questions we've got: how effective are the current treatments?
Okay, so for hepatitis C, well, maybe I probably should leave that till we talk about that. But to get to the point of your question, which was underdiagnosis, it's estimated that approximately 20% of people living with hepatitis C have not been diagnosed, and it's somewhat more for hepatitis B. Probably more than a third have no idea they're infected. And so that means those people have no choices about engaging with treatment and care. And for hepatitis B, it's a vaccine-preventable disease, so that their household and sexual contacts aren't being protected from infection.
And if we're talking about that hepatitis B mainly affects people from other cultures, and we don't have a structured screening programs for people who come to the country, unless they come under the humanitarian program, then they're more likely to be tested. Other than that, we really don't think of it unless there is a symptom.
Let's go to our first case study. This is Riley. She's a 20-year-old childcare worker who comes to see her GP complaining of nausea and vomiting, fever, aches and pains. And when you look at her, she does look jaundiced. Bob?
This young lady clearly has some illness upsetting her liver, giving rise to the jaundice, and the symptoms are systemic. So one would be thinking of a viral infection or perhaps some liver reaction to medication she may have taken. It'd be very interesting to know, I know she's a childcare worker, which puts her at risk of some virus exposure, but has she travelled recently? But I'd certainly be also wanting to push the question, has she taken any medications,
so
alternative medicines?
Which medications are there going cholestatic?
Some of the alternative medications can give rise to liver injury, probably fewer of them than we like to think. Antibiotics can cause cholestasis, some of the antihypertensives can upset the liver, so there's a range of drugs. I think you've just got to take
all
a
reversible?
Most are reversible if you stop the drug quickly, but certainly many people have died from drug-related liver disease over the years.
Because amoxiclav can be quite toxic to the liver, can't it?
It can, indeed. And Fluclox was one of the classical drugs doing that. But this lady's systemic symptoms do, I guess, drive you more down the path of a viral infection, which you'd like to sort out. Would it be hepatitis A? If she was living in the middle of a city, you'd probably not think of that as the first cause.
Why not?
Well, it's still a fairly uncommon disease, only 250 cases diagnosed a year in Australia.
Well,
so I think we do need to actually think about that and think that other causes may be more common.
Is she in an at-risk group?
She is at risk because she's exposed to children, yes, so there could be that. She may well travel, she may well have eaten somewhere unusual and picked up the virus that way.
What are the at-risk groups?
B and C.
Ben?
So Bob's touched on it, and I think a lot of hepatitis A diagnoses made and reported to health departments are related to overseas travel. The other at-risk populations include childcare workers, and another occupation is sewage workers or plumbers. Other groups who are at risk based on likelihood of exposure include men who have sex with men, and there have been outbreaks amongst men who have sex with men in the past. Another important group is Aboriginal and Torres Strait Islander people, particularly in some jurisdictions in remote areas, particularly WA, Queensland, Northern Territory and South Australia, have been identified as being at risk and therefore are prioritised for vaccination.
So what investigations are you going to do on it?
Well, I mean, I agree with Bob. It's important to take a full history. I think that she does need to be tested for acute viral hepatitis, and hepatitis A, as we've mentioned, she's a childcare worker. Often amongst young children, hepatitis A is asymptomatic or very non-specifically symptomatic, so you can have ongoing transmission amongst young children, and particularly if the childcare workers are involved in changing nappies, etc., they're exposed through the fecal-oral route in that way. I'd discuss risk factors for her for hepatitis B and hepatitis C and test accordingly. I think...
so you can have co-infection. Once you've got one, you think about another?
Yes, it depends again on the epidemiology. And other viruses like CMV and EBV, which again can be transmitted from children to workers, and I think that would also be part of the testing panel that we would...
So it's going to take a while to get your viral tests back. Presumably it's the transaminases that you're going to be looking at.
In part, so clearly if she's got jaundice and has the other systemic features, if this is a viral hepatitis, we could anticipate transaminases, well above 1,000 or 2,000 in that sort of a range.
And is there any correlation between severity and the level of your transaminases?
Not essentially. You can have, as we've mentioned, a very high transaminase and still have a complete resolution of the infection. Some of the factors that are associated would include if the level of bilirubin, so the jaundice, is continuing to increase over time and is not coming back down again, or if I did, as I would, do coagulation profile, and if there was a disordered or an abnormally elevated INR, for instance, that would herald that the synthetic function of the liver is becoming impaired, and that is a sign of fulminant disease.
So what's the proportion of people who, because hepatitis A, you either die or get better, or most people get better.
Yeah.
But how many people die?
Yeah, very, very infrequently. So it's less than 1%, and probably of the order of 0.2, 0.3%. One of the important issues here is that people who have other illnesses, particularly liver disease, so who have chronic hepatitis B or C, for instance, or other causes of baseline liver disease, are at higher risk of more serious outcomes of infection, and that's why, again, we prioritise vaccination against hepatitis A for people living with liver disease.
And in terms of spreading, would you immunise close contacts?
Absolutely. So household transmission of hepatitis A is extremely common, and so certainly health departments, one of the reasons that it's notifiable by clinicians throughout the country is that there's a window of opportunity to either give immune globulin or to give active vaccination to household contacts and to other close contacts to prevent infection.
And how do you make that decision between immunoglobulin and immunisation?
It's traditionally been immune globulin. That's a precious resource and it's a blood product. There's been recent clinical trials which have showed that hepatitis A vaccine is equally effective, so it's increasingly used hepatitis A vaccine in this setting of prevention of transmission. But
you've got to give a booster 6 months later.
You give a booster 6 months later to then get lifelong immunity.
Right. Yeah. And so just to nail that, we're talking about a fecal-oral route.
For hepatitis A, absolutely.
Is there any blood transmission noted in the literature? Or sexual transmission?
Yeah, well, sexual transmission, again, certainly that is the case. And there have been clusters of hepatitis A infections amongst people who inject drugs. But how much of that is actually through the fecal spread? Because we've already mentioned this is a very infectious virus, and if you've got high rates of household transmission, any substantial contact can be associated with transmission.
How long are you infectious for, Bob?
Some weeks, maybe 2 to 3 months. Once they have become acutely ill, the infectivity starts to fall, but you'd certainly be worried for at least a couple of weeks after the illness started.
And what are advice about alcohol and so on?
As with any liver injury, reduce any hepatotoxins to zero if you possibly can.
So no paracetamol and stuff like that?
No, and avoid those things that may just aggravate the injury and complicate the interpretation of the liver test.
And tell me about hepatitis E, Bob.
Hepatitis E is a second fecal orally transmitted hepatitis virus infection. It's a disease which has been reported well in India, Thailand, has caused significant epidemics there. The number of cases in Australia per year is only about 50, so it is here. And a number of clinicians were not aware of that even 2 or 3 years ago, but it is around, but it's not a major issue in this country.
We can test for it?
Yes, certainly we can test for it, and you'd have to think about it, anybody with an acute hepatitis who was negative to all the ones we'd normally do.
This is the one that's worse in pregnant women?
Yeah, E virus seems to be more dangerous in the pregnant women population with a significant mortality.
So you'd routinely test in somebody with jaundice, or is it not common enough?
I think if they hadn't been overseas and were living in Sydney, it'd be a very low risk that it was E, but I would look for it if I couldn't diagnose another virus.
Talk to me about hepatitis B, Ben.
Okay, so hepatitis B is a common problem in Australia, and it's an extremely important one worldwide. The WHO estimates it's the 10th most common cause of human death. And hepatitis B...
10th most common cause of human death?
Yeah, of preventable human death, that's right.
So that's from chronic hepatitis B or acute hepatitis B?
That's from chronic hepatitis B. The vast
Because when I was at medical school, they said, acute hepatitis B is really bad, you die of that one.
So the attributable mortality of acute hepatitis B is probably 0.2%, 0.3%.
So
again, high in people with baseline liver disease.
So it's similar to hepatitis A, in
Yeah,
fact.
it is.
Right.
But if you've got someone with chronic hepatitis B, and I'd like to stress, without appropriate treatment and care, then up to 1/4 of those people will die from cirrhosis or liver cancer. I think we guess later on how many people are living with hepatitis B in Australia, so I won't drop that one yet. But worldwide, 350 million people are living with chronic hepatitis B. It's the second most important human carcinogen after tobacco.
And when you track, I mean, we've got these statistics about hepatitis C, you have 100 people who get it, how many people untreated end up with cirrhosis. What are the figures for hepatitis B? The
fundamental determinant of the risk of progression to chronic hepatitis B, so after exposure, what proportion go on to chronic infection, is age. If infection, as occurs in the majority of the world, happens at birth or early in childhood, for a neonate, the risk of chronic disease is about 90%, whereas for an adult who acquires infection, it's of the order of 5%. So that's why high prevalence countries have traditionally stayed high prevalence countries, because of higher progression to, and there's the image showing the prevalence of hepatitis B worldwide. So the areas in dark green there are where more than 8% of the population have chronic hepatitis B. In the light green is where it's between 2 and 8%. And then the tiny minority, places like Australia, less than 10% of the global population, where it's less than 2%.
And by now people will have answered that question, so we can actually talk about modes of transmission.
Yes, okay. So the only one that doesn't apply in the Australian context is, or in any context, is uncontaminated water. It's not spread through the enteric route, but all of the other factors. So there was blood-to-blood contact, there was injecting drug use, and there was sexual contact. If I had to pick one from those, as an epidemiologist, I'd be answering and saying, well, what is the major determinant of transmission within Australia? And that's through injecting drug use. So that would be the number one prevention, apart from vaccination, of infection that occurs here. But on a global
Not sexually.
That's number two.
Right.
But on a global perspective, the vast majority of hepatitis B that progresses to chronicity is acquired at birth or early in childhood years.
So it's vertical transmission.
It's vertical transmission, and that's why vaccination of all infants including the first dose within the first 24 hours has been WHO policy globally since 2009.
And that's through breast milk?
No, breastfeeding does not increase the risk of transmission, nor does mode of delivery. And the one thing that can be done to reduce the risk is vaccination.
Can I just emphasize that point about vertical transmission? Because what happens is, from our experiences, when we have a clinician who deals with people from an English speaking background, we're not familiar with the context. That people have different experiences and different way of transmission. When we explain hepatitis B as a sexually transmitted disease, we're actually running the risk of impacting on the relationship and the mistrust between the couple. And we have dealt with a number of cases where actually divorce happened as a result of not engaging meaningfully with people from an English speaking background. So it's very, very important. I cannot emphasize this enough.
Yeah.
To differentiate between sexually transmitted infection versus mother-to-baby infection.
So just talk to me about infectivity and the surface antigen and the E antigen. What's the story here?
Sure. So the fundamental determinant of infectivity is actually the hepatitis B viral load, so how much viral replication is occurring. And
so it's like HIV in those
terms. It's
terms.
like HIV, it's like hepatitis C, it's like all these bloodborne viruses. E antigen is a protein which is a marker of a high degree of viral replication. And so that's a correlate of infectivity as well. But it's fundamentally the hepatitis B viral load.
Well, to what extent are prisons, because prisons are breeding grounds for hepatitis C, are they breeding grounds for hep B as well?
Well, they are. The hepatitis B is in the community, but because very few adults do keep the virus as a chronic infection, then there's not a lot of infectivity in that group. But if you look at a group of injecting drug users, most of them have been exposed to hepatitis B. Most of them have cleared it because they were adults when they were infected.
Jessica Dawson, a pharmacy student in South Australia, asks how effective is post-exposure immunisation Hep A and B? And when should it be used? So we've kind of spoken about Hep A. What about Hep B?
Giving the vaccine after exposure, I don't think there's solid data which suggests it is worthwhile doing.
Look, there's pretty solid data. I mean, I guess in a way, when we look at prevention of vertical transmission, that's what we're doing. We're giving vaccination after the exposure of the infant. You know, it's after the infant's passed through the birth canal, etc. In fact, that was some of the first data that suggested that post-exposure prophylaxis was a good idea. The fact that you could prevent the vast majority of Hep B transmitted to babies at the time of birth.
So who should you be doing Hep B testing on?
Yeah, so this relates to the prevalence of hepatitis B in the community. Now,
So clearly somebody who's got acute hepatitis, you would do it.
absolutely, but
But
there
with
are
all these undiagnosed people with chronic hepatitis.
Yeah, so for the people who are living with hepatitis B chronically, there's two priority populations identified in Australia, and that is people born overseas in high prevalence countries, and the slides coming up here demonstrating this by state and territory. These data are a little bit old. It doesn't add up to the correct number anymore. The correct number the estimate for the number of people living with hepatitis B currently is about 170,000 people in Australia.
170,000?
170,000. So it's people born overseas in high prevalence countries, and the second priority population is Aboriginal and Torres Strait Islander people. Now, those two groups alone probably represent more than 3/4 of people living with chronic hepatitis B. There are other priority populations in whom it's important to test, including people who inject drugs and men who have sex with men and people who may be occupationally exposed. The other important reason to test those groups is because they are at higher risk. We've got a vaccine. I mean, unlike hepatitis C, unlike HIV, this is a vaccine-preventable disease.
And the vaccine is not therapeutic in any sense. It doesn't have any effect once you've actually got it.
No, it can prevent infection after exposure, but if you've already got hepatitis B, it has no therapeutic impact.
Can I go back also to the detention, to the prison? Bob, you said about, it's more common for hepatitis C within the prison. But I just want to alert everyone that people in detention centres, such as the asylum seekers, if they come from high prevalence country. So there is evidence that hepatitis B is increasing within our detention centres as well.
So we're getting transmission?
Yeah, because they come with the disease and, with the virus.
And with a high viral load.
Can we jump in there and just say, instead of vaccine, if somebody's exposed to Hep B, there's the hyperimmune globulin approach to
Does that work?
prevent. That works, yes. As long as it's
So
given
that's
within a
specific
short
to Hep B, hyperimmune Hep B globulin?
And so it's usually given in combination.
Yes.
So the vaccine and the immune globulin to infants born to mothers who are infected, but also to other people exposed sexually or...
Talk me through how the progression to chronicity.
Okay, so we've mentioned the risks of transition to chronicity based on age, but once someone has chronic hepatitis B, there have been 4 predominant phases identified, particularly for those infected early in life, which I think we've got a graphic of. So for most people who have chronic hepatitis B and acquired it early in life, for the first 20 or 30 years or so, they're in what's called the immune tolerance phase. Now, there's no active liver damage or very limited active liver damage, but they're very infectious. The Hep B viral load is high and they're E antigen positive. When immune clearance occurs, as I've said, typically in the 20s or 30s, the liver function tests become abnormal. The E antigen is positive, but the immune system is fighting the virus. And that's actually, for hepatitis B, what causes all of the damage. It's not the virus causing damage to the liver, it's the immune system seeking to eradicate the virus. The hope is that people will achieve this immune control phase. This is what we used to call healthy carriers, and we never use that term anymore. This is characterised by low or undetectable DNA and normal liver function tests, and they're E antigen negative. The reason we don't call these people healthy carriers anymore is that approximately 25% of those individuals, the virus will mutate to escape from that immune control, and that's why we call the 4th phase immune escape. This is a group who is typically in the middle age. Their Hep B viral load comes up, the liver function test may be abnormal, they're at very high risk of progression to advanced liver disease and to liver cancer, and so that's why we're really trying to engage people who've previously been called healthy carriers back into care to receive treatment as appropriate.
And from that stage 4, what proportion will come down with hepatoma?
Yeah, so up to 25% of people living with chronic hepatitis B, active hepatitis B, will die from either cirrhosis or liver cancer. The proportion of hepatoma...
It's an extraordinary
Yeah,
percentage.
it's huge. So if you've got someone living with hepatitis B who is cirrhotic, there's a 2 to 3% chance every year of them developing liver cancer.
So it's 1 in 5 after 10 years.
Yeah, that's exactly right, and or even higher in some sort of populations for various reasons. And one of the groups we talked about previously, people from sub-Saharan Africa, are at higher risk of liver cancer earlier in life than people born in Asia.
Lucy McKinnon, a general practitioner from Victoria, asks, could you please tell us about the clinical use of E antigen and antibody in practice?
Yep.
I've used E antigen a lot because we grew up with that before we had HPV DNA testing, and it still is a useful serological test. If it's positive, then the virus is going to be highly active, replicating at a higher rate than if they are E antibody positive. So I think we do it, but in this day and age, the DNA testing is also very important. I think we shouldn't see one as excluding the other.
So that's different from viral load?
Now, the viral load is HPV DNA
so
testing.
that is part of it, right?
And you ask for
and it's
quantity.
Medicare rebatable for anyone living with chronic hepatitis B, so any surface antigen positive, Medicare will rebate a hepatitis B DNA once a year.
So a GP sitting in his or her surgery wanting to test for hepatitis B, what's the test they order?
Okay, so we need to separate this out into those who are wanting to diagnose someone or to assess their status for hepatitis B, and then the tests that are ordered for someone who has hepatitis B to try and determine what phase of infection they're in.
Right.
I think for someone who is wanting to test their patients who may be at risk of hepatitis B, there's 3 tests: the surface antigen, the surface antibody, and the core antibody. And one of the real take-home messages, if you like, is if you order all those 3 specifically on the order form, you can then get the results which will allow you not only to test if someone has Hep B or not, but if they've been vaccinated or immune, if they're immune through previous infections so that they don't require further testing or vaccination, or if in fact they're susceptible and need vaccination. So doing all those 3 tests allows you to categorise someone's hepatitis B status
without having to send them back for another test.
Immediately, without having to order the lab or bring the patient back.
So DNA is really for established infection?
Correct. It's for people who are surface antigen positive. And that's so doing the liver function test, the E antigen and E antibody and Hep B DNA allows you to determine what phase of hepatitis B that person's in.
Let's take a look at our next case study that focuses on Dr. Jill Benson's work, who's Medical Director of the Kakara and Willarara Health Alliance. She explains what is happening with hepatitis in remote Indigenous communities.
Aboriginal people have an enormous burden of chronic disease that really starts at a very early age. So we know that diabetes, cardiovascular disease, respiratory disease, renal failure, injuries, they're much higher. But one of the forgotten things is hepatitis B. Hepatitis B was originally the Australia antigen because it was discovered in the blood of Australian Aboriginal people. Most of the people with hepatitis B in remote communities have vertically transmitted hepatitis B, so this means that it's come from their mother. It means that 90% of those people are not going to clear that virus, so they have it for life. Getting good health care for those people, especially for those people who live in rural remote areas, has been almost impossible because in the past hepatitis B has involved having a liver biopsy before you could have treatment, and that's only really done in major centres. Most remote Aboriginal people don't like going to major centres. It also means that those people haven't had treatment because the treatment can only be given from a major centre. And there's all sorts of difficulties with the treatment for both hepatitis B and C that make the transient nature of Aboriginal people a real barrier to having that care. We have become used to the hepatitis B vaccination program, which in Australia is very, very good. And we forget the high risk that Aboriginal people still have. So the first thing is to make sure we're screening people. And every Aboriginal person who's seeing a GP, that GP should know what their hepatitis B status is, because being an Aboriginal person still makes you at higher risk of getting horizontally transmitted hepatitis B because there's so much hepatitis B in the community. And the risks of alcohol need to be discussed. The Aboriginal people who've been in jails have a high burden of hepatitis C. The treatment of hepatitis C involves treatment with interferon over 6 months or a year, and that needs to be continuous treatment. It's very difficult to have if you're moving around a lot. For hepatitis B, the treatment has involved taking medication every day, and it's really important that 80% of that medication be taken 80% of the time. That's difficult again if you're transient, if you're moving around from one place to another and that other place doesn't have that medication, you've forgotten it. So there's very few remote Aboriginal people in South Australia that are having hepatitis B or C treatment because of those difficulties.
Jill Benson. We've got a question here, we'll come back to Indigenous issues in a moment with a case study. We've got a question here from Pierre Giorgio Moro from Hepatitis Victoria. Do we have any idea how many adults in Australia get hepatitis B but then clear it?
Yeah, so if we're looking at people who have been infected as adults, then 95% of people will clear. If the question is what's the prevalence of previously cleared hepatitis B, then there's more than 1 million people living in Australia who have antibodies that show they've been exposed to hepatitis B but have cleared it.
Right, so it's not bad news for everybody.
Well, no, and it does demonstrate that the previous exposure is very common.
How well do you think we're dealing with these Indigenous issues that Jill's outlining, Bob, because you travel a lot in there?
Yes, modestly well, but not as well as we ought to be. This disease has been known to be affecting the community for a long, long time. The vaccination program is going well, but not all children stay around for the 3 doses of the vaccine, so that creates a problem. And there have been a number of cases of acute hepatitis B in children of age 12, 13, 14 in the Territory and in other parts of the country, suggesting the vaccine either didn't get given fully or they didn't seroconvert. And as far as delivering services to these people with hepatitis B, it's really quite patchy. Those living in the remote areas haven't been able to access biopsies for treatment easily. That's now changing in terms of the biopsy having been dropped for hepatitis B treatment. But even those that don't need a biopsy may not find it easy to get their medication supplied regularly. Yeah.
Which comes to having GP prescribers.
Yes.
Which we're agonisingly moving towards.
Yeah, look, it's fantastic. And the fact that 6 of the states and territories have agreed to be part of a pilot is I mean, 2
and you've got
years
5 nurse practitioners just champing at the bit.
We're certainly going to try and poach Tracy across to hepatitis B.
It won't work. It won't work. She's so committed.
Let's go to our next case study. Sorry.
I just wanted to raise the issue for migrant communities. I mean, we have to acknowledge that health literacy level is quite low. So we need to really engage with them in a creative way and use metaphors, there are a number of strategies, and I'll be more than happy to support people and share with them what we do with people. But one fundamental issue also, especially women who are put on treatment, which we all know that treatment can affect, the quality of life while they're on treatment. And in the meantime, they have a role to play. They have to clean the house, they have to cook, and so it affects their lifestyle. And while the rest of the family are not aware what's going on, they just all of a sudden feel this woman is no longer a good woman, or so it has a lot of impact, cultural impact, that none of us have thought about it. The other issue, and quickly I will mention the linguistic problems, is the use of interpreters. Often we are dealing with people who come from cultures and languages that are not accredited. So we use interpreters who we really don't know whether they
health
are...
literacy problems themselves because they're in not mainstream languages.
That's exactly right. So it becomes a challenge for us, and we really need to develop different ways, such as train bilingual workers. So they're not really interpreters, they're bilingual workers, which we do at Peace Program. So they are specially trained on how to explain things, because hepatitis B is a very complex, as we can, as we have just learned,
Yeah, try and explain immune escape.
Exactly.
To me, much less somebody who speaks Sudanese.
Yeah.
Let's go to our next case study, who's Stuart. He's 37 years old. He's an Indigenous man living in a remote community. He's hepatitis B surface antigen positive, as are his two brothers. His mother died recently of liver failure. He doesn't drink or he doesn't have diabetes. He is Hep B E antigen positive, has rising liver enzymes, normal alpha fetoprotein, and a viral load of over 170 million. He's anxious at the thought of leaving his communities. What are you going to do for him, Ben?
Well, I mean, clearly this is a gentleman who has chronic hepatitis B, and he's probably entering the immune clearance phase, manifest by the fact his liver function tests are becoming abnormal with no other clear cause identified. We know that his viral load is high. So, look, this is a gentleman who we would prioritise for further investigation and management. Up until Tuesday last week, we would have had to do a liver biopsy to access treatment. That's no longer required. And as we've pointed out, there's increasing focus on community-based care for hepatitis B, but this is certainly an individual that I would be wanting to investigate further with a view to embarking on antiviral therapy. So,
if he's anxious to leave his community, how are you going to do that?
Yeah, so that's why we're seeking to engage with primary care clinicians and nurses who are involved in the treatment of Indigenous people in remote communities. I think the liver biopsy removal is a fundamental part of that. The next fundamental part is increasing education regarding hepatitis B for doctors, nurses and Aboriginal health workers around supporting them in the management of their patients. I would ideally like to see treatment being given to patients like Stuart without him ever needing to leave his community, and just all completely through the Aboriginal Medical Service, who has been appropriately funded and resourced to do this, and harnessing some of the other chronic disease management sort of work that's been done for other important health issues for Indigenous people, such as diabetes and heart disease, etc.
So what are the treatment options here?
So for hepatitis B, there's two broad classes. There's the antiviral drugs, the direct-acting antivirals, and really the first-line therapies these days are either entecavir or tenofovir. The other broad class is the immune-modulating agents like pegylated interferon. The vast majority of people go onto an antiviral, be it entecavir or tenofovir. I think it's important to focus on the fact here that these drugs have been now shown to substantially reduce the chance of developing liver cancer. So for people who are treated for hepatitis B, within only a few years, the development of liver cancer drops by 50%. As recent sort of systematic reviews showed that. So
this is lifelong therapy?
It's indefinite therapy for the antivirals. So for the oral antiviral agents, they're extremely well tolerated. There's almost no side effects. But it does require adherence to therapy, and it's indefinite for the majority of individuals. For interferon, it's a defined course of therapy for only a year. It does involve a higher side effect profile, although not as marked as it is in the treatment of people living with hepatitis C. But the vast majority of people do end up going on antiviral medication, and that is often indefinite.
And monitored by viral load?
Yeah, so every 3 months, again, Medicare funds Hep B viral load 3 monthly for people who are being treated for viral hepatitis B, chronic Hep B, and also monitoring with liver function tests, etc. So I think the take-home point, if you like, for antivirals is that we need to use drugs that have a high barrier to resistance. Lamivudine, which is what we used to use, 70% of individuals had resistant virus 5 years into therapy. For entecavir and tenofovir, it's less than 2% at similar sort of durations. And that there are now effective options for people who have virus that we've made resistant through previous attempts at treating it. So these drugs are well tolerated, and what we really hope to see is increasing proportion of people being treated, because currently only 2.5% of people living with Hep B are receiving treatment.
And what's hepatitis D in all this? Because this is related to Hep B, isn't it, Bob?
Yes, hepatitis D was discovered in the 70s in Italy, and it's a virus which cannot infect an individual on its own. It needs the coat of hepatitis B to get into the liver cell to actually cause a clinical illness. And people who've got Hep B can either contract Hep D at the same time as they get Hep B, and that group often have a much more severe clinical illness and may die. The other situation may be somebody who's chronically Hep B infected, then meets hepatitis D and gets a super infection, sometimes with a flare of hepatitis at that stage. So it's an unusual finding in the human situation. In the plant species, there are quite a few of these viral particles that need another one to allow them to infect the individual plant.
We certainly have seen people, particularly from Africa, with co-infection. And as young as 20, under the age of 25, have hepatitis B and D, which really significantly lower their quality of life and the possibility of developing liver cancer or advanced liver problems. And we certainly have seen 27 and less than 25 years old have lost their life to liver cancer as a result of these two infections in South Australia.
It's nice to have it, but of course if you vaccinate against a Hep B and clear Hep B out of the community, Hep D can't cause a problem.
I've got a question from Adele Shannon in South Australia. Is there a concern about starting treatment for Hep B for patients with concomitant HIV? Does this promote resistant HIV, presumably because you're using anti-HIV drugs as well? Those drugs are used in HIV therapy too.
Yeah, so it's an excellent question. All the questions tonight have been really good. It's great. So there is a problem if someone seeks to start monotherapy for hepatitis B with one of the agents that's active against both hepatitis B and HIV. So examples include lamivudine or tenofovir. We even know that now that entecavir, which we originally thought didn't have any HIV activity, actually does select for resistance mutations in HIV as well. So that's the downside. But
so does HAART, highly active antiretroviral therapy, does that treat Hep B?
It does, and so that was the upside, is that if you treat the HIV with agents that include a backbone that is active against Hep B, so tenofovir and emtricitabine or tenofovir and lamivudine, then you'll treat both the HIV and the hepatitis B simultaneously.
Tracy, hepatitis C. But this is a different beast, isn't it?
Yes.
Not just in terms of the virus, but also the groups who get it.
Yes.
You're most forthcoming. Okay, they'll have answered the question by now. Tell us about modes of transmission and the at-risk groups.
Well, certainly injecting drug users or people who have ever injected drugs. People from countries of high prevalence. There's a risk of vertical transmission. We don't consider this to be a sexually transmittable disease. However,
it has been recorded, hasn't it?
Well, yes. Certainly in America, if you ask them, it happens all the time. There's been a recent study in Melbourne that shows that men who have sex with men have got an increased prevalence of hepatitis C. And,
particularly for HIV positive men who have sex with men.
Yes, thank you.
And what is it about being about HIV positive that increases the risk of Hep C? Is that sexual behaviour more than anything?
That's possible. I mean, sorry, did you want to take this?
No, that's fine.
So that's one possibility. HIV also affects the degree of viral replication of hepatitis C. So by suppressing the immune system, it means that the viral load of the person who has Hep C is elevated. And there may be a degree of serosorting. So people who are HIV positive having sex with other people who are HIV positive because there's no risk of HIV or new infection of HIV, but then transmission of Hep C occurring.
do you want to talk about the difference between prevalence and incident? You know, because for migrant communities, it's specifically important to understand that the older generation who arrived to Australia would have chronic hepatitis C as opposed to incidence newly acquired hepatitis C. Do you want to talk a little bit about this?
Ben can.
Ben can?
Very briefly, probably more than 90% of new infections of hepatitis C are through injecting drug use, but the proportion of people living with hepatitis C who acquired it through injecting drug use may be slightly lower, of the order of 80%, and maybe 10% or so, based on modelling studies, I should say, this is mathematical modelling, were through migration from endemic countries.
Right.
Sorry, I'll stop talking.
And there's also blood transfusions and blood products received prior to
Before there was testing.
1990, yes. And it's interesting, there are still people coming through the system now that you know, had absolutely no idea. And often that's children, you know, premature babies that receive blood transfusions, etc. after delivery. So.
But also going back home to their country, Vietnam, China, wherever, and do their dental care there because it's much cheaper, but they don't really look at the quality of care there. So, you know, any health promotion programs needs to take this into consideration. So it's not just injecting drug, although we know 90% of the infection, a new infection, is related to sharing injecting drug. But also there is, if you're talking about sharing injecting drug, I mean, drugs in different cultures have, it's not just, we're not talking about illegal drugs.
Yes,
you know,
yes.
sometimes diabetes,
Yeah.
you know,
Yes.
diabetic people sharing injecting equipment.
Yes.
It's quite common.
Yes. Tracy, just tell me about the guiding principles in the Hep C strategy.
I actually think the guiding principles, yes, they're in the Hep C strategy, but these are the guiding principles that we should be following. You know, everyone has the right to participate in the community without stigma and discrimination. And everyone should have the same rights to appropriate health care, regardless of whether they've got Hep C or not. And for me, Hep C doesn't define individuals. Hep C is part of that individual and part of that person.
So of 100 people who get Hep C, how many will end up with, it's cirrhosis we're worried about here rather than hepatoma, isn't it?
Yeah.
So what's
I mean, there's still, you know, a percentage of, you know, 1 to 4% that may develop liver cancer. It's still a real issue, and the reality of where we're at the moment is that because people are taking responsibility for their health and making the lifestyle changes that we've been recommending for the last 20 years, they're actually living longer with advanced liver disease, which means more people are going to develop liver cancer because that's the natural history. The modelling that we're quoting now was done quite some time ago, and we're actually now going to have to
So what
revise.
proportion clear the virus without any treatment?
About 25%.
So 75% retain the virus?
Yes.
And of them, how many will progress to cirrhosis or hepatoma?
Well, it's Hep C is
Without
a chronic
treatment?
Hep C is a chronic lifelong thing. So the cirrhosis develops over a long period of time. So if the person's not having any alcohol or, you know, contributing to the advancement of that liver disease, over a 40-year period, about 20%.
Right. So who gets treatment?
Anybody who wants it, has the will to participate and is prepared to, I guess, abide by the rules.
So, and there's different treatment according to the different type of Hep C that you've got?
There is, yes. Certainly genotype 1 is... people perceive genotype 1 as the worst genotype to have because they equate that with worst disease, and that's actually not the case at all. Genotype 1 is more resistant to therapy and therefore it's more difficult to eradicate, hence the longer period of treatment. Genotypes 2 and 3 are easier to eradicate or are more susceptible to current therapy and hence the shorter duration of therapy. But you have to take that into consideration along with all of the other psychosocial factors for an individual. You know, people contemplating going onto treatment, it's a massive event that affects not just them but everybody around them. You know, it often takes, I've got one patient, it's taken him 7 years to be in a place where he's ready to access treatment for the very first time. And what we know from our research is the first time people ever access therapy is the best time. So you actually do need to work with people to get them to a place where they can start and finish and potentially sustain a cure.
And unfortunately we don't have an immunisation yet for Hep C, but maybe one's around the corner, but I'm not so sure about that. Let's go to our next case study, which features the place where Anam works, which is the Peace Multicultural Service in Adelaide, raising awareness and knowledge of hepatitis in culturally and linguistically diverse communities. They work with individuals, families and communities by providing information, support and referral services.
I've been a GP for over 30 years, and for the last 11 years I've worked in mostly cross-cultural areas. One of my jobs is at the Migrant Health Service, which is a state government funded service here in South Australia. We are a multidisciplinary team, so our core business is refugees in the first 12 months after they arrive in South Australia.
P stands for Personal Education and Community Empowerment. We funded to work with people who are affected by viral hepatitis in particular, amongst the many topics that we do. And as you can see, we don't just work in the office or in our little comfort zone. We often are on the road, meeting clients in coffee shops, in community libraries, in their home, and wherever it suits them.
Relationships Australia has a program called Peace, which is really helpful for people with bloodborne viruses. They've got lots of really highly trained community workers who have health training in bloodborne viruses, and those people support the clientele that we send them in the system and in understanding their illness and in supporting them in what is sometimes a very difficult diagnosis for them, because it's something that has a lot of different meaning in their country of origin to what it has here.
What we really need to understand that people from non-English speaking background, they come often from cultures that is significantly different than mainstream communities. So they come, for example, from a collective way of thinking. So my issues is not just my own issues. It's not only my own private issues. You know, it is the whole family issues. If you've diagnosed a person with liver failure and you know that the prognosis is not very good, you do not tell the individual directly. This bad news is told to significant people in that person's life.
If people do have hepatitis B or C, we spend a lot of time talking to them about what that means here, because as soon as we talk about virus in your blood, people immediately think HIV, and they're absolutely petrified. So we have to move very slowly in our discussions about what hepatitis B and C mean, because the education and health promotion part of what we do is enormously important. And that's one of the reasons that Peace exists here at Relationships Australia, because they can spend that time with people educating them and making sure that they and their family and their community understand what these viruses mean in Australia.
We have social workers, counsellors, qualified case workers, obviously, and we have the bilingual workers. And if you like the bilingual workers, they become the foundation, if you like, of our work. Those bilingual workers, they live, breathe, they basically everywhere in the community. They are our eyes, they are our ears. They listen to stories, they know what's going on in the community, and they link their community's issues back to our service. And therefore, we design our services based on what's happening in the community and what's going on in the life of the communities.
Hi everyone, my name is Simon Grang. I'm from Republic of South Sudan. I'm 29 years old. I've got 2 boys.
My role involved case management and case work as well, and I support other support workers to work with clients. That's basically most of my role. And I also do health promotion education in the community.
My wife left me because of this sickness. This is what has happened. When we were in Africa, you had someone who got a liver problem, because you think that that guy, he will not be alive because there is no medicine. Maybe you think maybe I will not be alive or whatever.
So when they send Simon an appointment, they send me a copy. So when they send me a copy, I make sure that I remind Simon whether he's aware that the appointment is coming on the particular date.
but we certainly have worked and have had clients who've been referred to us from country areas. And initially we used the Skype thing. The local people in the community who helped us to help the client. And for those particular clients that I'm referring to, we actually got a staff member from our office in the country area to help the client access Skype and meet our one of our counsellors or caseworker and work and direct them and encourage them and empower them to go back to their local services. GPs can refer clients to us and other service providers. We definitely work in very strongly. We strongly believe in partnership. I always say when you work with people who come new to this country, you have to remember we have to be curious about what was their life like back in their country, what can I offer them here, and how can we put the two and merge the two together. So find out the old, tell the new, and work together to merge the old with the new.
The Peace Service in South Australia, and presumably, just very briefly, people have got to learn how to do this for themselves. You can't have a centre like that everywhere to do all the work.
No, I think you have to have the will, and when there is a will, there is a way, and collaboration is the key.
Question come in, is adherence to medications for Hep C and Hep B as important as HIV?
Absolutely, and even more so in the current climate where the new direct-acting agents are about to land on our doorstep. It's going to become absolutely critical.
And when is interferon actually needed, Ben? In the context of hepatitis B, when will we use that? So particularly in young people who have a high LT, E antigen positive, relatively low viral load, women tend to do better. So that's the sort of proportion, the people we try and prioritise for interferon.
And Goran Jovanov from South Australia asks, are people aware that after clearance of Hep C, they're still at risk, the virus, they're still at risk of liver cancer?
Once you've cleared the virus, liver disease settles down and the risk of cancer from that infection goes back to zero. But these patients are at risk of reinfection, which is a real concern.
So you don't have natural immunity.
Might be thinking about cirrhotic patients though.
In cirrhosis, if you're left with cirrhosis, there's a small chance your cirrhosis will reverse, in which case your HCC risk goes back down. But if you continue cirrhotic, your risk of HCC is real.
What training and education is available for professionals, Tracy?
Well, certainly for nurses, particularly through ASHM, there's specific hepatitis C courses, both online and face-to-face. And next year there'll be the first hepatitis B course that will be run. And there has been some discussion about practice nurses, although what I've found is a number of practice nurses, GP practice nurses, actually come to the advanced courses with the hepatology nurses because they get that opportunity for networking and it creates a much better collaborative relationship between the nursing sectors.
And just very briefly, Ben, the new testing guidelines or rules or whatever?
Yep, so the National Hep C testing policy is currently being revised and this is coordinated by ASHM and sponsored by the Department of Health and Ageing through various committees. And the new thing is that we'll have our first National Hepatitis B testing policy developed next year, again coordinated by ASHM. So
you can go to the ASHM website to find out more about this?
Yeah, there's lots of educational resources there too in both Hep B and Hep C.
Yes.
Good. Take-home messages?
There are so many.
You've got about 20 seconds here, Anam.
I think we need to be creative. We need to find a way of engaging more effectively with people from non-English speaking background. Test. Go find it. Find people who I'm sure you will.
Go hunting and fishing. Okay. Yes. Tracy.
The guiding principles that were in the strategy are relevant to all chronic diseases, not only Hep C. The hepatitis C is curable and that the lifestyle modifications are critical for the whole person for any chronic disease.
Ben.
So liver cancer, the vast majority of which is attributable to chronic viral hepatitis, is the equal fastest increasing cause of cancer death in this country. Both the national Hep B and C strategies prioritise innovative models of care, including nurses and primary care clinicians. And so we really need to invest in that process to make a difference.
Know the appropriate at-risk populations, test accordingly and offer treatment when it's available.
Thank you all very much. Great
Thank
program.
you. It's been a pleasure.
And I hope you've enjoyed the program too on viral hepatitis. Our thanks to the Department of Health and Ageing for making the program possible. And also we've been helped by Gilead Sciences for additional support. But above all, thanks to you for taking the time to attend. And special thanks to Relationships Australia and Jill Benson. If you're interested in obtaining more information about the issues raised in the programme, there are a number of resources available on the Rural Health Education Foundation website, rhef.com.au. Don't forget to complete and send in your evaluation forms to register for CPD points. I'm Norman Swan. I'll see you next time.